A great success story for me is Mozambique. They were having many adult deaths. It was about 8 to 10 a month, unexpected within the first 24 hours. And they went down from 8 to 10 deaths a month to 1 to 2 a year. And so it's not resources, it's about the people. It's about unleashing the power of the people to be safe.
Welcome to Leading Quality, the podcast spotlighting the people moving healthcare forward from the front lines to the C-suite. I'm your host, Jason Meadows. Dr. Peter Lachman is one of the major international figures in patient safety and healthcare quality improvement. He's a pediatrician by training, but his work has reached far beyond one specialty or one health system. He has served as Chief Executive Officer of the International Society for Quality in Healthcare, was Deputy Director for Quality and Safety at Great Ormond Street Hospital, was a Health Foundation Quality Improvement Fellow at the Institute for Healthcare Improvement, has helped educate quality and safety leaders around the world through his work with the Royal College of Physicians of Ireland, the Patient Safety Movement Foundation, and several major Oxford University Press handbooks on patient safety, medical leadership, and quality improvement. But what makes Peter such a compelling voice is the way his career has followed the evolution of patient safety itself. His path into the work began long before patient safety had a formal language. As a young doctor in South Africa, he was involved in the aftermath of a fatal medication error that shaped his understanding of harm, human factors, and the limits of blaming individuals. Later, in the United Kingdom, he worked through major system failures in child health, maternity care, and hospital safety. Then, through formal training at IHI, he found the theory and methods to name what he'd already been seeing in practice. That harm is not usually the result of bad people, but of systems that make harm more likely. In this conversation, we talk about the evolution of patient safety from professionalism and regulation toward system thinking, proactive risk management, culture, and co-production. We talk about the SAFE program, his work spreading safety practices across very different health systems, and his current argument that safety has to be embedded into the genome, as he puts it, of healthcare workers. The deeper question running through this episode is how we make safety part of the way healthcare thinks, trains, governs, and works. I hope you'll get as much value from this conversation as I did. Dr. Peter Lachman, welcome to the show.
Thank you. Thanks for inviting me.
You're very welcome. And I wanted to start at the beginning. You have spent decades working in patient safety and quality improvement, and I'd like to know what first drew you into this work.
Well, you have to go back to my work in South Africa as a young doctor. I didn't know it was going to be my work in quality and safety. I worked in South Africa in the time of apartheid in a very progressive unit. I was head of child development. But even before then, as a young trainee, my first safety event was when a child or a young baby died because of a human factors error. And this is where the baby came into our very well-designed Toyota's lean system kind of diarrhea room. And you had the entry point where the babies would be assessed. And then where the babies were in three different stages: those who required IVs, those who required oral, and those who were going home. And we're talking about 30 coming in during the day, 30 going out, and another 70 lying around on this. They were assessed every 4 hours. Very protocolized, very standardized. Way before we spoke about standardization, we were doing it in South Africa. None of us knew that how advanced we were in lean thinking. We didn't call it lean thinking then. But the critical thing was that you had to make quick decisions and you had to follow the formula. So we were asked, the baby would come in and they'd say, Is the baby dehydrated? Yes or no? Usually yes. What percent? 5, 2.55, 10. That was a guess, but we had guidelines of what they were. And then how much fluids did the baby need? And was the baby acidotic? Yes or no? And if the baby was acidotic, you had to give Sodabic, and you had to give 5 mils, 2.5 mils. You had the formula. Everything was standardized. In fact, you didn't have to think much. You just had to follow the protocol. And this baby came in, 5 mils Sodabic was requested, and the young doctor received the vial, injected, and the baby died. And I was the resident at that stage, the registrar, my first week of being a registrar, and I had to inform the parents that we had killed the baby. I didn't say it that way. Now, what had happened is that in those days, the flaw in the system was that potassium chloride and sodium chloride weren't kept side by side. In glass vials, there were glass vials, potassium chloride was red writing and sodium chloride was black writing. So it was a human error. As a human disaster was waiting to happen. And the nurse in the rush, as you recall, there's 30 babies, they're very busy, there are a lot of sick babies outside, and they pressurized, opened the wrong vial, because sometimes you use potassium chloride, and put it on, and the doctor failed to check. And yeah, that was a human factors error before we knew about human factors. And that was 1984. So it's way before the safety movement happened. I was introduced to my first major safety event, in which what happened was that we didn't have second victim support that Chris may have spoken about. The young doctor was put up for manslaughter, as was the nurse, because baby had died, they lost their jobs. I kind of sublimated and put it away in the back of my mind and moved on to the next thing. But it was very traumatic when I think about it now. But it was going to influence my career path, in which I became involved in many, many rescue events over my career. But that was my first safety event when I was a young doctor. And when anyone who's listening to this career path, okay, to this podcast, that each of them will have had a sentinel or an adverse event that would remind them of what I now call the big why. The big why are we in patient safety? Why are we in this work that we do? And I know my big why was that if that happened today, that young doctor would still be a doctor. That baby probably would still be alive, because potassium chloride is now a scheduled medication. You have to go, and it's kept separate from the other medications because of its danger. People don't about it. Although when I go in Africa, I still find it amongst not locked away. I even find it in private hospitals. I find it there. So that was my start. My start was when I was a young doctor. And then whatever I've done since then has been involved about quality and safety without even knowing I was doing it until I formally became involved in 2000, even though I'd been involved before. Oh, I can give you lots of stories if you want to, Jason. But that's the start story. That's the start story. And then I recall there was even before then, I had another start story as a medical student. So there are many, many stories.
Yeah, and it sounds like the way that people in charge viewed that story had a huge impact on the trajectory of that nurse and that doctor. And how did people view patient safety? What was the prevailing view of patient safety, maybe at that time and in the couple of decades until you kind of formally got into patient safety?
So just remember, when I graduated in '79, we it was presumed that being a health professional made you safe. We swore the Hippocratic Oath. That's what we actually did do that. First, do no harm. I remember this ceremony. I can visualize it. First, do no harm. As we graduated, we had no idea what harm we were doing. Absolutely none whatsoever. We had no data. There was nothing called patient safety. It just assumed that by being a doctor, you would be safe because you're a professional. Professionals are safe. That's what was assumed, but we had no idea. Absolutely none whatsoever. I mean, a lot of the world now still has no idea, but then there's no such thing as patient safety. It was, you will be a doctor and you'll be safe. And that was it. And there's no safety in our training. Even now, there's no safety really in the training. Human factors, no one heard about human factors in those days. So it was just assumed that you'd be safe just by being a doctor. Then you go into systems, and I must admit that I was at a very top class hospital, this Red Cross War Memorial. We had really, really good systems. We had lean systems, even though they weren't calling it lean. We had safe systems, but no one was calling them safety systems. I wasn't being trained in patient safety. We weren't talking about it like we do now. It was a totally different world. I did work in many different fields. I was in community child health in those days. As in when after my training, I went into community child health for a few years and headed the child development. And a lot of my children I saw were from unsafe acts in obstetrics and maternity, the highest risk area of medicine. So even though I didn't know it, I knew that there was medical misadventure, medical harm, and I knew that it was there, but there was no one had a theory or basis about it. And actually, patient safety really only started in 2000 as something really important with the As Human and in the UK with organizations with the memory. And that's when patient safety started around about then, actually a bit earlier with the Harvard studies. Even though if you now look at quality, quality really started with Codeman in 1920, saying, well, we have to know that the outcome, the end product of surgery, what happens to the patient. And then there was the Joint Commission started a long time before, and they were all measuring in some kind of ways. So there were quality. If you look at the history of quality, there were things, but it still wasn't. It was viewed very much from a regulatory and professional point of view. If you're a professional, you'll be good, and then you have to follow some regulations and standards. But how you reach those standards, which is the quality improvement part, no one was talking about it. Only really Deming came into patient safety, into quality in the 1980s. So in the 1980s, Deming got interested in healthcare and the start of the quality movements in healthcare started in the 1990s. It's not that long ago, 30 years ago, that it started in healthcare, even though Don Obedient started in the 80s. So it's 80s and 90s where things were starting. And I'm one of those who can say I'm from just before the quality movement started, during the quality movement started, and here I am now.
And so with that longitudinal perspective, from a time, as you describe, where patient safety was assumed and whether a patient was safe or not, if I'm reading between the lines right, it really had to do with individual success or individual failure. And then you mentioned 2000 being the year that you really got into patient safety formally, which was a really important time. As you mentioned, Two Areas Human came out the year before, and then the year after that in 2001, Crossing the Quality Chasm came out. Was there a lot of optimism at that time that healthcare could become dramatically safer?
Okay, just remember that those are very American assessments. There I was in South Africa, and to Earth's Human, I never heard of it. I was an attending, we call it attending, consultants in Cape Town, running child development. We were very interested in systems and system control. Really working in a political environment, we were very, very involved in social determinants of health way before the upper income countries were. So we were very politicized in the way we looked at healthcare. So what we said, the health outcomes are due to political decisions and social determinants of health. Nowadays, it's very fashionable in the upper income countries to talk about social determinants of health. But we were talking about it 25, 30 years ago, doing things to decrease the social determinants. But the systems ideas that came in was quality and to err is human and so on. I only heard about it when I went to IHI in 2004-5. So 20 years ago, I was in IHI. But before then, I was managing many different quality issues and safety issues out the theory and backing about it. So I was a leader, and we knew we had standards. So if I take it backwards, in my early career was in Cape Town. I was head of child development at the Red Cross Hospital. I had a good career path. I was quite happy. We were very innovative. I had a big interest in system failures, particularly in child protection, and systems failures related to social determinants of health. So we always viewed it through that eye. And then when then a nurse murdered a few babies in a rural area in the United Kingdom, in Grantham, and I had done some training, post-apartheid kind of training. Went out to Nottingham, and then they asked me to come and sort out the problem for them. And what has happened was a total system failure. They didn't recognize it. The system had failed to allow this nurse to murder these babies. And she was giving the babies insulin, and no one noticed that. And then 4 died and 8 others were injured. And major inquiries, they're like inquiries in the UK. And then they needed someone in to come and change the system. And I came in to change the system. So I went there in 1994. I said, I'll come for a year or two to change the system. And I stayed on there for 2 years and told them that the system needs to change totally. And there are not enough children. And so I worked with that system, and they eventually changed it as I recommended and closed that small community hospital where the problem happened because it was.
And if I could just interrupt you for 1 second there to clarify the case that brought you there with the nurse. These were also accidental administrations of insulin, or these were intentional?
No, this was intentional murder. So she murdered 4 babies. Her name was Beverly Allett. It was one of the major cases. They had a major inquiry. And I came as an outside set of hands to assess the system. And I still didn't have the training. And as I look back, it was a systems failure, not the nurse. She was a cog in the system that allowed her to murder these 4 babies. And I learned then that what I teach now in patient safety, 1 death is a tragedy, 2 is a coincidence, and 3 is a pattern, and that you can stop it after the 3rd. And she had about 11 in the pattern, and not everyone died, so they could have stopped her much earlier. Unfortunately, there's a current one called Nurse Lucy Letby did the same kind of thing, they allege, and that was many more babies in 2016 to 2018. So the lessons often are not learned. But I came to the UK to sort out a system failure, and I've started to get interested in how systems work and how can you design safer systems, still without the knowledge, because of course I came there in 1994, and still To Earth's Human hadn't been published yet, so we were still before patient safety started. So there was no science behind what I was doing, and I hadn't read Don Obedian. But it's right. System process leads to outcome. That's for sure. And I hadn't read the Harvard studies. So because I was just here, I was working my way through this. And then the next big challenges were child protection challenges against systems failure, where the system of social care and the system of healthcare, the system of the police allowed major challenges in healthcare, in outcomes of babies. And there was one or two big cases. One was called Victoria Climbier, the child who died way beyond after she came to our hospital. But it was a system failure in retrospect. But of course, they wanted to blame the individual, always the individual. Which individual made the mistake, rather than what was wrong with the system that allowed this to happen. And so system theory hadn't started yet in 2000, when 1994, definitely, my first big case. The second big case in 2000 definitely hadn't started. In 2000, I was at a hospital in North London, and I was head of pediatrics, became head of obstetrics and gynecology, mainly because there's a system failure. And I didn't understand yet the systems failure. And then we had a number of maternal deaths. And then people say, which obstetrician's at fault? And no, not an obstetrician at fault. It was the system was at fault. It's only when in 2004 I went to IHI that I suddenly had my eyes opened and said, wow, this is theory. But that's only 4 years after To Earth Human and to Crossing the Quality Chasm. So I got there very early on into the program. I was very, very lucky as an IHI Health Foundation Fellow to sit in the same office as Don Berwick and Maureen Bissunano and learn from Deming's disciples, Lloyd Provost and Bob Lloyd, etc., and Tom Nolan, on system theory, and that it's not this individual, but it's a system. In most cases, in the nurse who murdered the baby, okay, she was murdering the baby, but the system allowed her to murder the babies. The system could have allowed her to murder the first baby or the second one, but not the third. Can you see? So, so in 2004, my whole focus, even though I was a medical leader beforehand, my whole focus changed to patient safety. So in the last few minutes, I've been telling you my journey from a very first patient safety episode, which in retrospect was my first human factors failure that I witnessed. I was a third victim, not even the second victim. I was the third victim because I was advising the second victim who caused the first victim. But I didn't even realize then, till many years later, that was the starting point, and that each of these cases that I was going to solve in child protection, and I was very much involved in child protection, were all system failures in child protection, not individual failures. And then when I moved out of child protection back into healthcare, that all the cases I was dealing with were mainly systems failures. And the maternity cases at the London hospital there were very good people there, but the system failed them. In the child protection case, the system failed them. And even though there is individual accountability, there was no just culture, and still now it's the same kind of issue. So my journey then really started on this over the last 20 years. That's what I'm more or less dedicated my career to. And that's been particularly even more so the last 5 to 10 years. I've been trying to think of new ways of doing things.
And I'm eager to get to that. I'm curious, from that 2005 to 2006 fellowship period, how did your work change during and right after that?
Well, after 2005, I was at Northwick Park Hospital. I was a medical director and head of the obstetrics and pediatrics dealing with these issues. And then when I went to IHI, I came back and I moved to Great Ormond Street and Royal Free. At Great Ormond Street, I was head of quality and safety, and I had a team that we could really develop new ideas that I'd learned at IHI. So IHI gave me the theory. So now I came back with the theory and method. And so I worked at Great Ormond Street, the Royal Free, and then also at the National Institute for Improvement and Innovation, which gave me places I could experiment. So at the Institute, I was involved in developing the pediatric trigger tool for the UK, the pediatric early warning score. We were rolling that out till they dissolved it when the new government came in. We were educating quite widely. I was in a program, national program I was delivering for them, with them was on national, what was called Leadership in Patient Safety, called LIPS. It was very advanced training teams from across England. It was mainly England. I was also involved in working in Scotland then. And so from 2005-06, I was very much in patient safety because at Great Ormond Street, we were implementing patient safety, and at Royal Free, it was my laboratory. So at Royal Free, a big teaching hospital, but it's a pediatric department, but it was my laboratory. And there we could test ideas that I would later on take to the institute or to the for national or to the Great Ormond Street. So I was very lucky and in my role, because I had a role in patient safety. It was one of the first roles in the country where you'd have a patient safety officer, and we call it a medical director in the UK, and where we were funded very generously by the board of the hospital to be innovators in patient safety. And over those period, we implemented many, many good programs at Great Ormond Street and the Royal Free to innovate and be leaders in patient safety and quality. So I was very fortunate to do that from 2006 to 14. That was my major focus.
I wanted to pause for a moment to invite you into something I'm starting with this podcast. If something from this episode connected with your own experience, where you've seen it work or not work, I'd love to hear about it. There's a short link in the show notes where you can share what you're seeing in your own work. It takes about a minute. I read every response, and over time, I'll be sharing what we're learning together in future episodes and in other ways, and giving shout-outs during future episodes to people in the community who share ideas that really move the conversation forward. If you're up for it, I'd really value your perspective. Thanks.
I understood that one of the things that you implemented at Great Ormond Street Hospital was a safety event and near miss reporting system for patients and families. And this is something that you published on. Can you tell me about that?
Yeah, well, this is even before co-production had come into the fore. That co-production only came in 4 years later. I was always ahead of the game a little bit sometimes. So here we thought that actually the people who know their children best are the parents, and they are with the child. And one of the things about Great Ormond Street, the parents stayed with their children when they were admitted, in many cases. And so we developed this tool with parents over a period in order for them to be able to identify potential harm before it happened. So the scoring tool was quite simple. It was we looked at a number of indices that the parents would identify: medications, were the medications given on time, were they the right dose, were there any problems with them? Communication was always a big thing with them. There were specific ones we had in that unit that we could pull out. They could identify specific ones. Anyway, so what would happen on that with that tool was at the end of the day, the nurse caring for the child and the parent would sit down and they'd fill out the form together. And what we noticed was quite interesting, is that nurse reporting of incidents went up, of potential incidents went up, and serious incidents went down. So reporting went up, but serious incidents went down. And it was before psychological safety. We didn't have that word, but we were building psychological safety because we were talking about patient safety. The other one is that more or less around the same time, we had a partnership with Cincinnati Children, because when I was at IHI, kind of they didn't know us, interviewing the top hospitals. I went to Boston, Philadelphia, San Diego, one in San Francisco, and Cincinnati, to see who's the best in patient safety. And when I walked into Cincinnati, I said, wow, this is different. Just walking in, I could feel there's something going on here. So Uma Codigal and Steve Merton were the leaders there. So I said to Uma, would you like to partner with us? And of course, Great Ormond Street has got an international reputation, and it's the Children's Hospital, and I felt we needed to have a partner in helping me drive through the changes I wanted. So we linked up with Cincinnati. And then I visited Cincinnati quite a few times, and there was a lot of cross-pollination. Uma would come to me, and we'd go to Cincinnati, and the CEOs got friendly, and they come back and forth. So when they published on the huddles, we started doing them at Great Ormond Street, which then we honed in at Great Ormond Street, and then we took it national in the UK, the SAFE program, Situation Awareness for Everyone. And that was started from the publications that Cincinnati brought out. They brought out 2 publications on their huddles. I saw what their huddles were like, and then I adapted them for Great Ormond Street and for Royal Free. We tested it out at Great Ormond Street and Royal Free, so there would be one in what we call a smaller hospital and one in the Children's Hospital, and then we rolled that out. We had a big program funded by the Health Foundation in 2014 to 16 on the SAFE program. It was called Closing the Gap in Patient Safety. And so I rolled that out. And then I've taken it around the world and to Ireland. And I think that's actually my biggest impact of anything is the SAFE program. And that program, which we started at Great Ormond Street, we started seeing increased reporting, but decreased harm, decreased CLABSIs, decreased VAPs, decreased, you name it, whatever we're going, we were decreasing and making the hospital a much safer place. And because people were talking about safety. So if I look back in my career, there have been a lot of innovations, but I like to think about the SAFE program. This is on the safety side. On the quality side, it's a Lachman program, but on the safety side, I like to think the SAFE program is a way which brings together all the theories of patient safety to the frontline staff and allows them to be safer without them thinking about it. If they do the SAFE program every day, they will have a safer program, a safer outcome. So that's my passion, really, that one, the SAFE program.
And for our listeners who heard you share just now about the SAFE program and then Flockham, worth mentioning that I believe you're the chair still for the Flockham board and had a big role in designing that along with Chris Van Hocht, who was one of our recent guests, and listeners can go back and check out that episode with him. I would be curious to know about the SAFE program in terms of you described some of the successes you had. I'm curious about the spread. So spreading to other countries and maybe what proved universal and what proved very context dependent, having to be changed and adjusted for different places.
Well, actually, it's theory, as I say. It's like gravity. Apples fall to the ground in every country. So the SAFE program works in every country. The biggest problem is time. Do we have time in the day to talk about patient safety? And I'd argue, yes, you do have time every day to talk about patient safety because you're saving time if you're talking about patient safety. So I've done it in Australia, Argentina, Sudan, Mozambique, no resources. In Mozambique, we amend it in each place as context. Context is always important. Started doing it in pediatrics. So when I moved in Ireland, we've trained over 100 hospital teams, from obstetrics to medicines to EDs to pediatrics to psychiatry, just teaching people how do you talk about safety looking forward? How do you come to reactive to proactive management of risk? The premise starts like this, is that we work in a very high risk environment. When I trained, we were coming out of the period in which patients died from one condition. So, for example, in neonatology, for example, when I graduated, we didn't have surfactant. So babies over 1,000 grams, under 1,000 grams, we didn't even bother to ventilate because we didn't have surfactant, because we knew they were going to die. It was straightforward. It was very difficult. The young doctors saying, we're not going to ventilate. Now we ventilate 250 grams. But in those days, 1,000. That was it. Then surfactant came, and in comes the baby survive. And with the survival, we now get line infections, VAPs. We get all the other things from that survival. So we created all these safety issues on the neonatal side. Now I can go to the other part where most people die, the elderly. So now people live longer. So what happens? We created a whole lot of safety problems for the people who live longer. They fall, they get dementia, they get delirium, when you bring them in hospital. So now we have falls programs, dementia programs. We create the programs because of our success in medicine. So the more successful we become, the more complicated it has become. And we're playing catch up. And so what we've done mainly, in the big mistake in patient safety, was that it was about managing risk retrospectively. Someone got harmed. Who did it? What went wrong? Rather than doing it proactively and saying, well, we get it right most of the time. How can we predict who may be harmed? Who's at the highest risk of harm in the next 8 hours? And that's what the SAFE program's about. It's about identifying risk before it happens. It's based not on the theories of Charles Vincent, who actually, and Alberti. Well, Charles came to Great Ormond Street and studied us as one of those case studies in 2012 on measuring patient safety, and that came out with a whole theory. And then out came Holnagel a few years later about saying we also have to look at what we do well. I put the two theories together. They called it Safety 1, Safety 2. And then Charles wrote a paper on proactive healthcare with Alberti. And I put all these theories. My idea was that how do we get frontline staff, clever people who want to do the good work? How can we get them to do it as part of what they do? And so we developed a SAFE program, and that evolved over the years in different ways. So in the first year, it took me a year to teach it, and now I do it in 6 months in shorter periods. Honed it down. If you say what has happened, it's very focused. What do they need to do to be safe? How can we get them to be safe? The first step is getting the big why. Why are you in healthcare? It's a moral responsibility to be safe. It's a moral responsibility. That's why we're in healthcare. And okay, what do we do really, really, really well? When do we do, and then what don't we do so well? Well, that's the adverse events. Who do we harm? Understanding it, contextualizing it, and then moving to the solutions, reliability theory, what we do well, standard operating procedures, how do we follow them and why not when we don't, what's the reasons, human factors analysis. We use the SEEPS model, systems engineering and patient safety that Pascal Currion, and so they can start looking at the work system. Do we have the right patients? Do we have the right people to care for them? Do you know what their tasks are? Can they do their tasks? Do we have the right equipment? Now we get to the context in lower middle income countries that don't have the right equipment. How are we going to mitigate the right equipment? How do we organize ourselves? What's the environment like where we work in? Which are the risk factors? And then what are we learning? They do the cycle two, 3 times a day. And it becomes part of their genome. And a great success story for me is Mozambique, is that when I went to Mozambique in 2016, working with the health service executive in Ireland, and I was at ISQA at that stage, another part of my career I haven't spoken about, but I was at ISQA and I made it part of my work to go to Africa. And a ward said children would die, adult ward, they were having many adult deaths, and they counted them. So it was about 8 to 10 a month, unexpected within the first 24 hours. And I was just in the middle of the SAFE program. I taught in the SAFE program and of identifying proactively who may deteriorate ahead of time and intervening beforehand using those cycle I just went through. And they went down from 8 to 10 deaths a month to 1 to 2 a year. What does that mean for your listeners? That means over 90 families had a father or mother survive. And we even asked them to check what happens after 48 hours. Did they die after 48 hours? Because they would know that they lived. And then what happens after COVID, when they ran out of the monitoring? We used something from Australia called Between the Flags. What happened when they ran out of the monitoring forms? And they said to me, no, so we've internalized it. This is what we do now. We do it every day. And so it's not resources. It's about the people. So I've had to realize when you ask me the question about safe in different contexts, it's about unleashing the power of the people to be safe.
And it sounds like such a rich framework for operationalizing the talent and the skills and the dedication of people already working on the front line. You mentioned the word, genome, bringing it into the genome of healthcare workers. And I know that's something that you've written about as recently as 2025 for medical education and what medical education has to do to embed patient safety into the genome of future healthcare workers. What can you tell me about that?
I got that idea. Well, the Mozambique story I've just told you is that in 2023, when we went back there, they told me it was in their genome now. They said we've internalized it. So now I didn't say genome. And then when I was commenting on a paper, I reviewed a paper on psychological safety, and then the editor asked what the journalist said, would you write the paper? And we came up with this idea about the genome. And it all derives from what those Mozambicans told me, that they had internalized patient safety where they worked. They didn't have to think about it, it's what they do. Okay. So I started thinking about this concept of genome with my colleague here, John Fitzsimons, who I work with close in Ireland. And the idea about the genome is that if you insert something into the genome at a young age of the young doctor or nurse, then that's what they do. They don't say, I don't have time, because that's what they do. So that's the metaphor. The metaphor is the genome. And saying, well, medical education has failed because it has not inserted quality and safety into the genome of the future or healthcare workers. Just as it's going to fail by not inserting how to use AI safely into the genome of medical workers in the future. I mean, it's not doing it now and says, oh, in 10 years' time, we better tell them how to use AI, then it's far too late. So it's always the education is is always behind. Why? Why is it behind? Because they say, oh, we don't have enough time. But I don't need to know. In the old days, when I trained, I had to memorize the Krebs cycle. Nowadays, you don't have to memorize the Krebs cycle. You know how to use the Krebs cycle because you can have it on your iPhone. You can ask Claude, tell me what the Krebs cycle or ChatGPT, and out it comes. You don't have to memorize anything these days. It's one of the dangers, of course. You have to understand how to use these things and interpret them. AI is not going to replace you, but AI is going to help you understand things and apply them. So it's applications, same as patient safety. We've got to insert it into the genome from the early age. And that means that when they come into medical school, it's the same stream as physiology and pathology. So it runs alongside physiology and pathology, patient safety and human factors. It's not, it's taught as a separate science, but interwoven. So my idea of how you would do it is that for the medical student, when they say, this is a typical thing, they'll say, please examine Jason and tell me what you find. Then they'd say, well, I was taught, well, Jason comes with this condition. The anatomy, this is how I was taught, the anatomy is in the cardiovascular. The pathology, the pathophysiology is atherosclerosis. The pathophysiology is, then I'd say the safety issues are, can you see? Straight away, along with anatomy, pathology, pathophysiology, then you'd say, or even they'll say the differential diagnosis is, and within that are the safety differentials. These are the high risk things for him. And this is what the medications we're going to give, and these are the risks of the medication safety. So if it is the care of the elderly, it will be thinking about in this person, what are the risks of this person falling because I give them this medication? Not saying we have to have a falls program, but of the doctors thinking about, well, what's the most common causes of falls? I'm not a geriatrician, but the most common causes of falls are delirium and patients being given sedatives and medications that cause them to fall. And then they have a falls program to prevent falls. I say, are you ridiculous? Just start thinking about it proactively, and you'll decrease the number of falls amazingly if you start thinking in a different way. And not going to have that falls program, you just have a proactive medication risk program. So it's moving like SAFE program then says to people, where you work, what are the harms that happen? What happens? Tell us the lived experience of your patients, or as we call them, the people sometimes known as patients. What is the lived experience of those people?
That's right.
Not of patients. And what's the lived experience of the people providing care, sometimes known as doctors and nurses? Because of course we're all people. And what is that lived experience? And of course they'll come back and say, this is what happens. I'll say, okay, let's decide how we can co-produce in the SAFE program, how we can have a safer environment and come together to eliminate those harms. And they eliminate them. And some people are doing falls, some people are doing eclampsies, other people are doing deterioration. The whole idea is proactive management. Because when we get to the S, what will be safe in the future? That's the prediction. What's going to happen? Who is going to fall before they fall? Who is going to have a medication harm before there's medication harm? Who's going to deteriorate before they deteriorate? So it changes the game. And I really believe that if every clinical team was talking about safety in this way, we had dramatically decreased patients' adverse events. We wouldn't talk about adverse events in the same way we do. And that's where I said earlier, I think safety went the wrong route. It spent all this time talking about adverse events, what went wrong, rather than looking at proactive risk management.
Yeah. And as you're alluding to, that's been very slow to change. I'm curious how that idea about embedding safety into the genome has been received. Are there any med schools reaching out, wanting to do that? I can imagine, as you're kind of anticipating there, some people pushing back and saying we don't have enough time to teach, the anatomy and the physiology and everything else. But this is deeply, deeply important. And so I'm curious if that's any med schools have taken you up on that.
I got no idea. It was from my first publication, Medical Education Journal, and I haven't had feedback from them. But I'm talking the safe programs, the remedial work, doing it while they're healthcare workers. The genome is just beforehand. So you can stick it into the genome when you're training your residents. So you can do the same time. It's never too late to put in the genome. Never too late. Put it that way. So while it's for medical schools, really where I'd like them to start, I'd like also when the residents or registrars have been trained that they get it into their genome. Of course, we also have to do it for the attendings and the consultants because their genome is deficient because they think they've got it, but they haven't. And the idea about safety is that you have to talk about safety every day. As I said earlier, it's a moral obligation. It's not a something you do when something goes wrong. It's about safety is our business, not healthcare. Healthcare is very complex. Our business is keeping people safe in our healthcare system while we treat them. And it's changing the terminology, the way people think. And I should be really very despondent because of 25 years, healthcare has come a long way, but not far enough. It has to change the way we think. And the genome is my latest idea. Okay, so it's a metaphor is that you've got to do it early. And it's a challenge to medical educators to think how they do it. So I can see some medical schools have got patient safety as part of the curriculum, but not every medical school will have a professor of human factors, a professor of a department of patient safety, doing research into patient safety. In the United Kingdom, you're supposed to do patient safety as part of your work and to get appraised, but still, it's an add-on rather than what we do. It's what we do. It shouldn't be an add-on. And it's a change of thoughts. And it goes back to culture and how people think. But the genome is my latest idea. So, I'm hoping medical schools say, yeah, that's a great idea. And we go because genomics is very popular these days. So maybe they understand the metaphor and apply it.
Yeah, I think it's a stickier metaphor. I think it's a stickier metaphor in today's conversation. There's two other groups that I think you're probably interested in inserting this into their genome, as it were. One is, as you said, people who are already practicing, whether it's physicians or other healthcare professionals. So I wonder if you can comment a little bit on that through your work as the fellowship director for the Patient Safety Movement Foundation. And maybe at the same time, you can tell me about your work with boards and how boards can enhance safety or not, and how we kind of put that in the genome.
Yeah, okay. So let's start with the genome is what I'm doing now. I'm actually looking at ways we can do remedial genome therapy, I guess I called it. So a few years ago, I was asked if I'd help develop a program for the Patient Safety Movement Foundation for an international program. So they're an interesting group because they're like a social movement, and they develop patient safety solutions, but no way of really implementing. And they asked me if I could help develop a fellowship program which they had started or help do it. That was in 2003. So I said, okay, they're based in California. So I direct their program for early to mid-career healthcare providers. So we take any healthcare provider, from doctors, nurses, pharmacists, occupational therapists, physiotherapists, whoever wants to apply who's involved in healthcare and delivering clinical care generally from across the world. And I'm really aiming at low middle income countries, but this year I've got someone from the US, and I've had I've got someone from Belgium, from Chris's team actually, on the program. And we started with 4, then we went to 6, then we went to 10, then we went to 12, 18, 12, then to 18. And this year we want to go up to 32. So we exponentially grown each year. I've trained 45. And it's about inserting the genome. So I've worked out a program of what do they need to know as leaders in patient safety, which is what's the material for the insertion. And we spend a year doing that. And we use each year the program has evolved, because when you go from 4 to 18 to 36, you've got to change the way you deliver it. So in the first 1 year or 2 years, I was delivering a lot of the stuff. And then I decided a flipped classroom is better when we get to 12. And then when we go to 18, like this year, last year and this year, they go into learning sets, or 3 or 4. And they have a mentor for the learning set. And the mentor mentors them in the learning sets. And then they present and they teach each other. But they also learn reflective practice. So this is where I see if it's working. So every month they have to write 2 reports for me of reflections on their learning of the previous presentations, and also of a project they have to do, so I can see if they can apply what they're learning. And the idea is to really see how we can insert. And it's a model that people can take and apply at scale. And now we're scaling up. We're scaling up at the moment. So I'm going to see what happens to 32, and then people copy them. Nothing's copyright yet, because I have a very detailed program in which they learn a different series of patient safety, but they also learn the stuff we teach on Lachman, which is co-production and quality and so on. So what Chris would have spoken about. So we start with that: equity, quality, person-centered care. Before we don't even talk about patient safety, it's all round 3. Then really about going to culture, and then we go into the technical part of patient safety, and then we end up with well-being of staff. So it's a very intense. It's kind of, these are people from so we have from Africa, Asia, Latin America, Eastern Europe, the eastern part of Europe, and 1 or 2 we take a year from the upper income countries, because I was really focusing on those who don't have. Because if you're in the USA, in many programs you can go on, and this is totally free. We were fortunate, Joe Chiani, who started the Patient Safety Foundation, from his foundation, he funded it and continues to do so. This has now become a big part of what Patient Safety Foundation does. And they can apply. And what they get is from me, they get mentoring in terms of monthly feedback. Then they get an individual mentor who's a previous fellow, because we're trying to build the movement. So a previous fellow does it. And actually, this evening, we have a guest speaker for all the fellows of all the years. So we now at a stage in which we're saying, well, how can we get this to be a fellowship that lasts forever? Because what is a fellow? If you read Lord of the Rings, it's about fellowship. And And this is what I'm trying to build, this idea of this international community of practice of fellows who are learning from each other and supporting each other. So can you imagine that, for example, in Latin America this year, because this is my latest iteration of thoughts. Before I had one or two from Mexico and one from Brazil, but this year I have Argentina, Peru, and I think there's Argentina, Peru, and Nicaragua meeting as a cell. Argentina, Peru, Nicaragua. And then they are mentored by the previous ones from Brazil and Mexico. So now you have Brazil, Mexico, Argentina, Nicaragua, Peru. Okay. And next year, I'm going to look if I can get one or two other countries. And now in Latin America, I'll have a nexus of pediatric leaders across different countries supporting each other. That's in Latin America. There is a lone USA person in California, and he's linked into the Latin American, so he's learning Spanish very quickly if he doesn't speak it. And then if you look what I'm doing in what we're doing in Africa, we have a West African and East African group, because we've got quite a few from Kenya and Uganda and Ethiopia. And then we've got the Southern and West African group. Then we've got a group in the Emro region. So what are basically building groups across the different WHO regions. So each WHO region, PAHO for Latin American Americas, Afro, Euro, Emro, CRO, etc., will have a group of 6 to 10 fellows by the end of next year, or may need up to 10. There will be 60 that I'm going to try to equalize them out, supporting each other, and then working together as an international group of fellowship. And that is set into the genomes, and their job is to do likewise where they're working, is to take it and teach and continue the program and start a social movement. Because the other idea I have about patient safety is that one of the problems is that it was a product, but it needs to be a social movement. Just like climate change is a social movement. And people need to be seen. It needs that kind of spread. So you need a lot of network theory and community of practice theory to get it spread. And this is the innovation I'm trying to do with the Patient Safety Movement Foundation. Throughout my career, I've been very fortunate. I've had hosts who've allowed me to play around with new ideas. So the Patient Safety Movement Foundation is my latest place. Great Ormond Street was a place I could innovate. National Institute was a place I could innovate, where I was allowed to think about those things. And of course, I haven't spoken about ISQA, where I was CEO for 5 years, where I could innovate new ideas to develop patient safety and quality. So in each of the organizations that have employed me, I've been fortunate that the boards have allowed me to do that. So that's part one of your question. Part two of your question is about the boards. So I chair two boards on one board. The first board is the FLACOM board, which Chris has asked me to chair because that came from a paper I did with Prof. Paul Batalden and Chris on the multidimensional model, thinking what is quality really about in the new age, and we published in 2021. And from that came the House of Trust in the FLACOM model, which your listeners can listen to, about thinking about quality differently, mainly because I was thinking with Paul Batalden, who's the great thinker in quality, is why is it not working after so long? And with Paul, we're currently thinking about the problem has been is that we treated quality as a product, not as a service, and patient safety as a product, not as a service. And products are transactional and services are relationships. So we trying to think a little differently of how we do that. And FLACOM is a good example of how they're transforming a product into a service. And so accreditation is a product, not a service. And so FLACOM is a service, not a product. And that is the Lachman board. The other board is I've been working with a group in India called the Consortium of Accredited Hospitals, CAHO, Consortium of Accredited Hospitals Organizations. And they had a social movement, and they were quite interesting. I met them when I was CEO of ISQA, and they're very inspirational. And they accredited hospitals, but know they have to do more. And so they a social movement spreading across India. I work with two groups in India as well. Another group is a national point of care of quality for neonates, and I go to there every year. And that's because India, of course, is so big. You've got to think of social movements to spread quality and safety. And in the last one is a group in Africa and Kenya called Acquire, and they also a bottom-up safety movement, and they asked us to be on their board as the quality experts. And my idea, the reason why I agreed to do that was because I wanted to see how, because I've worked a lot in Africa, is there a way we can get a grassroots movement going for quality and safety in lower middle income countries, low resource. The resource is the people. So the India and the Africa versus the FLACO, which is high income, is that it's all about how can we create these social movements where the people, that's the doctors and nurses and the healthcare providers, meet the people, the patients and their families, and co-produce quality and safety and get good outcomes. That's the future.
And from that, from the experiences you've had on these different boards, from the incredible volume of experience you've had in patient safety, for listeners who might be on a board or want to expose their board to important ideas for how they can support safety work better, what kind of advice would you give to people who are wanting to make the boards more able to support safety?
I think the first thing, at the bottom line, everything is about culture. It's about talking about your culture. What's our culture here? Not what's our vision statement. What is our culture like? What do we talk? A culture is what you do. It's what you think. It's who you are. And it gets you outcomes. So I'd say the first thing for a board member is to be curious. Always ask questions. Be curious. You have to have courage. I said this applies to everyone. So curiosity, courage. You have to always be someone who gives hope. People don't like negative stuff. You've got to give them hope. It's always going to be better, even when it's not. People don't vote for negative, they vote for hope.
Yeah, well said.
So politicians sell hope, they get elected. Politicians sell negative stuff, they don't get elected.
Yeah.
So that's those three things: curiosity, courage, hope, and always be transparent. Always be transparent and learn.
Yeah, thank you for that reflection. I as I'm thinking about all the different pieces of work that you're doing with the Patient Safety Movement Foundation and all of these other areas that we've talked about, if the work that you're doing kind of achieves its highest aspirations, let's say on the next 5-year time horizon, what does patient safety look like?
As I said, part of me is very pessimistic because things aren't moving as fast as they should. Another part of me is very excited because we've come as far as we can. I think that we're at the next phase of evolution with AI, which we've got to say, well, how's AI going to help us be safer? How's AI going to help us? And I give you, for example, it's early days still, but AI is going to have the right algorithms to help us diagnose sepsis earlier, for example, or AI will be able to tell us who's at highest risk if we put in the features, and they'll tell us who's at highest risk. But it's not going to be the answer. The answer is culture, of course, is that we have to have a safe culture. So everyone says more tools, electronic records, and all of that. Oh, those are expensive ways to have bad outcomes if you don't have a safe culture. It's all about culture, you see. So am for me, I think that when I look globally, people are starting to talk about safety, which is really good. The politicians are starting to talk about safety. The WHO has been talking about safety. But have I heard, I'm just going to use, I'll use the UK and I'll use the USA. I haven't heard your Secretary of State talk about patient safety. Putting the way we talk about patient safety, and I haven't heard about our guy talk about patient safety the way I want them to talk about patient safety. So we have to get the politicians at the highest level to talk about patient safety and quality. They like to talk about it when things go wrong or negatively, what we're doing, but it should be at the heart of what any policy is going to be done. And then we've got to really think about healthcare and how we've designed healthcare for the modern age. So I started when I was a child. We still had polio. Then we got vaccinated and we had no more polio. We still had smallpox and we got vaccinated. No one gets vaccinated for smallpox anymore, but I've got a smallpox vaccination. No more smallpox. Measles, mumps, rubella, you name it. Infectious diseases was what happened in those days. Now, this was the age of infectious diseases when I grew up. Then we moved into the age of cancer. And now that was the next age where we're sorting out the age of cancer. We're still in that area, but a lot of times now, and I can speak as someone who has cancer, is that we are in an age where people are living. And because we've dealt with infectious diseases, we're dealing with cancer, we now got the non-communicable diseases that we're dealing with. So people are living, but they've got diabetes, they've got obesity, they've got all these things. But what has happened is that the healthcare structure hasn't changed. We still have these enormous hospitals, very big hospitals. The medical education hasn't changed at the scale it has to do in order to create the doctors of the future who can deal with the problems of the future, the diseases of the future, which are going to be non-communicable diseases because people are living longer, both in upper and lower middle income countries as well. Because as they're going to get there rapidly as well, because as you get more wealthy and people living longer, so people go through. So what we have to do now is say, well, how can we treat people with chronic disease and not treat them in hospital, but treat them in the community? And that's where the work I'm doing with Paul Batalden, or the thinking I'm doing with him, I'm very privileged to able to work with him now, is on how we think about not managing disease, but managing health. And how can we co-produce health rather than manage disease? Because I really don't want to be seen, or a person doesn't want to be seen as a diabetic. They want to see as a person who's got grandchildren, who likes going to the theater, reads books, and so also happens to have diabetes as part of the portfolio, but can live a full normal life because can you see? And that's now changes the game. And I think we're still in a disease management system. And because we're in a disease management system, patient safety is still in that product system. So I'd like to see the change over the next 5 years. Now, you can't jump from one to the other straight away. You need all of these levels. So in the paper we wrote with Chris and Paul, and we spoke about quality 1.0, 2.0, 3.0, where 1.0 is accreditation, regulation, meeting the standards. Essential, you have to have that. Quality 2.0 is meeting improvements. That's Durand and Fleming and so on. And quality 3.0 is the co-producing of health, and looking how we can look at the architecture that you do that in. And I think that healthcare needs to rethink it's what it's going to do, how we train the future doctors and nurses to think differently about when someone comes to see them, they mustn't be talking about their disease, but talking about their health. And of course, safety becomes part of it because it's in their genome. And how can you do this safely, and how can you work out the risk profile for individuals as part of the assessment? And I think we're getting there. My optimistic side now is talking is that people are talking about this, and I see clinical teams now doing things differently. Doctors are doing it, and hopefully people are buying the books I've written, so that will help them do it, because that's another sign. 15 years ago, no one would have asked me to write those handbooks, but now they're asking to do it. So that's the kind of thing. So I see the changes. So I'm very optimistic, and I know change takes a long time. But since I started on this journey many, many years ago, at the start of my career, the world has changed in patient safety. Has it gone far enough? No, but it's gone far away. and I think that you said the next 5 years.
Yeah.
Well, I don't think we're going to be solved in the next 5 years, but we're away on the way going there. But everyone needs to start thinking differently. The people we call patients, because they're sometimes patients, they're people most of the time, the people we call healthcare providers, they all need to think differently about patient safety. And I'm lucky I get asked to speak on quite a few different conferences around the world, and each time I'm honing my idea of what they have to think, how they want to think different. I spoke to the Flarkham group last week, and I came up with this idea about the moral imperative. So it's a moral imperative. So it's about morality. It's about who we are in healthcare. And as soon as you start talking about people, that's the why. Why are we here? And safety and quality is part of caring.
Yeah, I think that vision and that optimism is something that will resonate a lot with people listening to this conversation. And I want to thank you for taking the time to have this conversation with me. For listeners who want to follow your work, I will include links to all of the resources that we've discussed today, but is there anywhere in particular that you'd advise people to go if they want to connect with your work or follow your work?
Well, they can just go to the LinkedIn page and connect with me. That's the easiest way they can do that. Like I'm advantaged now that I'm kind of retired, but I'm not retired because I've got all these activities going on, and people can reach out to me, and I always respond generally pretty quickly. And if, as I said, if people particularly in low middle income countries want to compete for the Kiani Fellowship, they need to do so. And there are other ways that I can support them. My final thing is that I was fortunate, very fortunate, that I was able to get onto the bus very early on when it started. So only a few years after To Err is Human, I was in quality and safety, learning about it, 2005. So 5 years later, I was there. And now I've got the opportunity to give back, and that's my role. I see is to be able to get the next generation of quality and patient safety leaders around the world to overtake it on. And the more we can do, and this Kiani Fellowship, that's one way. Thinking new ways of sending out ideas, that's another way. I really think that it's what we have to do. And hopefully the podcast will inspire someone to say, I want to learn more. And they're welcome to contact me.
Dr. Peter Lachman, thank you so much for joining me today.
Thanks a lot, Jason. Great to be here.
Thanks so much for listening to today's episode of Leading Quality. If you enjoyed the show, please take a moment to like, subscribe, and share it with someone who might find it useful. You can find all our episodes at leadingquality.buzzsprout.com or in your favorite podcast app. The show was written and hosted by me, Jason Meadows, edited by Milan Milosavljevic, and produced by Thrive Healthcare Improvement. See you next time.